Experiences of a new UK sciatica pathway, a qualitative interpretive study. And that's from Claire Ryan.
Hello, I'm Claire Ryan, and today I'm presenting the findings of our qualitative study that explored how patients experience being managed as part of the new UK sciatica pathway. In recent years, NHS England has increasingly focused on the need to deliver care that's high value, responsive and integrated. Aligning with this and to support the delivery of best practice, the new UK low back and radicular pain pathway was established. In this paper, we sought to understand how patients experience being managed within a UK sciatica pathway. This was a secondary analysis of a qualitative interview study. The qualitative study was based in the UK Musculoskeletal Interface Service, and at the time of collecting data, the new pathway had been in place for 16 months, and the service was working to align its practice with the pathway recommendations. Our sample consisted of people with a clinical diagnosis of sciatica who had seen a clinical specialist and had investigations. We collected data using individual semi-structured interviews and analysed the findings thematically. Our sample consisted of 14 adults, 8 were female, and the sample ranged in age from 34 through to 81 years, with a median duration of symptoms of 13 months. We identified 3 key themes: problems with the pathway, required agency, and the burden of agency. We define agency as the independent and proactive actions patients are required to take to manage their health. Patients identified that a series of problems with the pathway made it difficult for them to manage sciatica. Neither the pathway itself, nor the individual services, nor the risks and benefits of individual treatments were transparent to patients. Patients struggled to contribute to decisions about their care, and sometimes their individual needs and circumstances were not heard. They described being able to access specialist services and investigations as protracted and difficult, and they did not feel that the pathway services worked collaboratively. The second theme that we identified was required agency. It was apparent from our data that to manage sciatica well, patients were required to be proactive and independent. This related to their ability to navigate the pathway, but also to access resources outside of it, such as information, the experiences of others, and private treatment. It was also apparent that patients perceived that to be seen to be a good patient, they needed to be proactive and independent. The third theme that we identified was the burden of agency. It was apparent from our findings that being required to act with agency was burdensome and difficult for patients. This was partly because of the impact of sciatica, but also because patients that they lacked the required skills, the necessary support from the pathway, and the funds to continue with private treatment. So what do these findings add? Each of the problems that we identified with the pathway have previously been seen in either the low back pain or sciatica literature. Despite these issues being highlighted in the new national pathway, our findings indicate that in practice our data indicates that this may be due to a culture of paternalism, of protocol-driven care and siloed services, and perhaps also a failure to fully embrace the concepts of person-centred and enabling care. In relation, our findings indicate that it has become normal for patients and clinicians to expect patients to act with agency when they're managing sciatica. Whilst this is a new finding in the sciatica population, it is well recognised in the literature about managing long-term conditions. Whilst this might simply be a societal, neoliberal norm, our data indicates that it was burdensome and difficult for patients to be required to act with agency. This finding aligns with the burden of treatment theory that indicates that when patients receive insufficient support from healthcare, they struggle to self-manage their condition. Now, this was a small single-site study, and further research is now indicated to comprehensively explore the experiences of those who are managed for sciatica within the new pathway. However, we argue that our findings importantly indicate the need for services to align closely with pathway recommendations and also to consider how they can deliver person-centred, enabling and supportive care. Thank you.
Thank you very much. May I just remind moderators not to play around with the layout or the videos. When it changes layout, it does interrupt the sessions and people may not be able to hear the videos clearly. Thank you very much. If you'd like to continue.
Go on, Michelle.
Thanks, Claire. So the next talk is from Sarah Liddell, talking about the Watching Pregnancy project. So if you're okay to play the next talk.
Hello, my name is Sarah Liddell, and over the next 5 minutes I'll be giving you a brief synopsis of the Watching Pregnancy project findings. Low back pain during pregnancy is relatively common and can often persist after birth, thereby potentially contributing to the overall problem of low back pain in our society. Yet to date there have been limited UK-based research studies in this area. So the Watching Pregnancy project was designed with 3 objectives in mind. Firstly, to test the feasibility and acceptability of the proposed methods of recruitment and follow-up in one UK-based NHS trust. Second, to prospectively explore women's low back pain experiences, including the effect of low back pain on their function and quality of life, and to collect information about low back pain related healthcare use from initial presentation of symptoms until 6 months after birth. So pregnant women with no previous history of specific spinal pathology, serious spinal pathology, recent spinal surgery, or a UTI were asked to complete 4 bespoke online questionnaires at 4 separate time points, 2 during pregnancy and 2 after birth, as shown in the slide. Women were asked to report low back pain, plus or minus referral to the lower limb, that lasted for at least 7 days. There was no stipulation at any point in the study for women to either have low back pain or to have had a history of low back pain. We wanted to find out if this developed and what sort of impact it had on women's lives. So over a 7-month recruitment period, we identified 477 women who could be included in the study, and we sent out 477 questionnaires, to which 307 replied. And were successfully recruited to the study. Attrition was approximately 50% over the course of the study, right up until that 6-month after birth timeline. This slide shows a few things. Firstly, the blue bars represent the percentage of women experiencing low back pain at each study time point, and the lines represent the predominant healthcare use that was reported by the cohort of women. The red line representing painkiller use throughout the course of the study, and the green line self-referral to physiotherapy. And as you can see there, painkiller use was actually more dominant and more popular than self-referral to physiotherapy. When we look at whether these painkillers were prescribed or not, we can see that the majority of them were not prescribed, which is an interesting and concerning finding because we don't know what the effect of painkillers have on the unborn child. So that was an interesting finding in itself. This slide represents changes in patient-reported outcome measures of health-related quality of life and back-specific function. And both of these outcomes deteriorated sufficiently from the first time point to questionnaire 2, 31 to 33 weeks, to have a clinically meaningful impact on the individual. Interestingly, low back pain adversely affected health-related quality of life, most in women with a history of low back pain, and most considerably at the questionnaire 2 time point. This slide represents women's fear avoidance beliefs of physical activity, and physical activity is typically used to self-manage low back pain that is non-specific in nature. And we can see that it's relatively high throughout the course of the study, and it doesn't, the fear avoidance beliefs do not actually decrease to the same extent as the improvements shown in health-related quality of life and function. So that could have potential implications for self-management of symptoms in the future. This slide just represents what women felt about taking part in the study, and how difficult or how easy it was to take part in the study. And you can see from the majority of these comments here that they actually found that it was very easy to take part, and the feedback was very positive overall. So it was worthwhile doing the actual study from the women's point of view. So in conclusion, the study methodology is definitely feasible. We will need a longer recruitment period, and also a full-time, a future fully powered study will need a full-time researcher in charge of recruitment. However, it does show, we've shown here with this preliminary work, that there has been a clinically important change and deterioration in health-related quality of life and back-specific function as a result of low back pain. And there is a disturbing use of painkillers over other conservative treatment. And I just want to take use this last slide just to acknowledge those who made the study possible. Thank you.
Thanks for that, Sarah. That was very interesting. The next speaker is Stephanie Jansen Kostering, who's going to talk about the acceptance of clinical decision support systems amongst clinicians in the treatment of neck and/or back pain in primary and secondary care settings.
Hello, my name is Stephanie Jansen Kostering, and I'm here to discuss with you my research focusing on the acceptance of clinical decision support systems among the clinicians in the treatment of neck and low back pain in primary and secondary care. But first, I want to present to you what these kind of systems are. These systems are software tools designed to support the clinical decision-making process and have the potential to translate the up-to-date knowledge into practice. There's input, there's an output, and based on simple or more complex algorithms, there is a simple or of a classic or a complex clinical decision support system. And within this research, we focus on these complex systems. These systems have a proven potential to reduce medical errors and to improve the quality of care. However, the uptake of these systems remains low, and the main reason for this is a black box effect. Clinicians are aware of the input and the output of the system, but not of the decision-making algorithm within the system. And therefore, we want to focus on whether or not people or clinicians are accepting these systems in their daily clinical practice. For this, we use two methods, a focus group and a questionnaire. The focus group were conducted with clinicians working within a rehab center, and the questionnaire was sent out to GPs, PTs, and also clinicians working in a rehab center. When we focus on the results of the focus group, we see that these participants were more willing to use the simple or the complex or the classic clinical decision support system than the more complex ones. When we focus on acceptance, they were enthusiastic, but there was also some reluctance to use these kind of systems. And when we focused on the facilitating conditions, they stated that it should be easy to use and easy to access the system, but also that the data should be stored safe and that it should be technical robust and transparent. For the implementation, they stated that they needed sufficient time to train and experiment with the new tool, and they would like to be involved within the co-design of the system. For the questionnaire, we asked people to look at this animation because not everybody is aware what a clinical decision support system can do for them. There's no sound, but I will read with you. So please read the text on the screen to follow the animation. After this animation, we asked people whether or not they wanted to use the system. And the three main reasons to use the system were to improve the care, out of curiosity, and also to increase the efficiency. We also asked what the reasons was not to use this kind of system as presented in the animation. The first reason was that they were worried about their own clinical practice and autonomy, that it could be too expensive in time and cost, and that the system didn't work correctly. So given the outcome of the focus group and the questionnaire, our conclusion is that clinicians are willing to use a complex clinical decision support system, but that we have to take into account the following recommendations that were made. The system should be used as an add-on instrument. It should help us. The final decision rests with the practitioner. That's stated by the participants. It should be mainly used during the intake phase. It should be work technically well. It should not be presented as a black box, and there should be plenty of room and time to train with the system. Next to this presentation, we also write down our results in a paper that's available preprint. Please follow the link for this. It's good to mention that this work is performed within the backup project, and if you want to have more information on this project, please click on the link. Thank you for your attention, and I hope we have a good discussion.
Thank you very much, Stephanie. Hopefully we'll have some questions for Stephanie coming into the chat very soon. Our final presentation before we go to the questions is Holly Clark, who's going to talk to us about developing a pathway for the management of patients presenting with suspected myelopathy within secondary care.
Welcome to our presentation on developing a pathway for the management of patients presenting with suspected myelopathy in secondary care, presented by myself, Holly Clark, Carla Evely, and co-authored by Leanne Wood, all spinal ESPs working at Nottingham University Hospitals. The most common cause of cord compression is that of degenerative cervical stenosis. Progression of this degenerative change to myelopathy is thought to occur in 8% of those with degenerative cervical stenosis. Progression is difficult to predict, so difficult to always know when to intervene with surgical options. At this time in 2017, there was no national or published guidance on the management of this cohort of patients, and inconsistencies in their treatment and management pathway was found, with often reliance on consultant input to guide treatment decisions. Following review of a published systematic review in 2017 titled A Clinical Practice Guideline for the Management of Patients with Degenerative Cervical Myelopathy, written by Fellings et al., a pathway was developed, adopting the principles and findings outlined in the article. This was peer-reviewed by the ESP lead and the spinal consultant team, with agreement to trial the pathway in the secondary care ESP clinic. Due to changes in the service and the addition of an ESP-led acute emergency assessment unit, an updated rapid literature review was performed, and the pathway was updated to reflect the changes. This has recently been approved at the end of 2020 by the consultant physiotherapy lead and surgical consultant team.
Let's look at the pathway. For patients with proven cord signal change, if they present with a sudden onset of symptoms or acute deterioration, they will be referred to the on-call fellow and our acute unit for immediate assessment and surgical planning. Should patients present with a stable presentation, they will be safety netted and discussed at the next MDT for surgical consideration in a routine manner. The MDTs take place every 2 weeks with one of the spinal consultants. Patients with cervical stenosis, but without cord signal change, that present with radiculopathy would be safety netted and be very much part of a shared decision-making process regarding their management. They will be monitored within our team, and if there's evidence of symptom progression, then they will be reclassified and treated as appropriate. Patients with cervical stenosis, without cord signal change and without radiculopathy, would be counselled and safety netted. They will be followed up within our team, and again, if there's evidence of symptom progression, they will be reclassified and treated as appropriate. If they remain stable, they can be discharged with safety netting advice. The pathway has been used in our ESP outpatient clinic for the last 3 years. We have also developed a patient information booklet to support the pathway, and this includes myelopathy safety netting. A small audit took place after the development of the initial pathway. However, this data was of small quantity and not significant enough to show effectiveness. Anecdotally, clinicians have found it a useful tool to support decision-making. On our acute unit, case studies have shown the pathway to be effective. Patients with sudden onset of symptoms or acute progression have appropriately been referred for urgent review. A retrospective audit of the effectiveness of the pathway is underway. This uses MJOA scores, MRI findings, patient presentation to measure against the pathway and the actual management outcome. We hope to complete this study this year, and with possible further studies into patient experience regarding the management on the pathway. Thank you for listening.
Fantastic, everybody. I hope all the speakers are able to join us now for some questions. I think there were questions for Claire, who presented the qualitative evaluation of the sciatica pathway, that related to the next steps or the actions you might take in light of your findings. And I wonder if you could add a sort of second part to that question in terms of, if you'd done this study 10 years ago when there wasn't a pathway, what do you think the disparity between your pathway findings and your unstructured care findings might be?
Thank you, Jim, and also Anna for the question. So in terms of next steps, first of all, so we first of all did a piece of work to try and understand whether their findings were more generalizable and still current, so where patients still struggling with these same issues. And we looked first of all at rapid access, and found that yes, definitely most patients were not meeting the pathway timeframes for accessing imaging and further interventions. And that's really where the first steps were, to try and get more rapid access. So really being able to highlight patients who were urgent or had severe radiculopathy to get them to the next step. And that was through just setting up a specific process that we could request urgent injections, and also highlight that in virtual clinic to be able to move them through the pathway faster. In terms of some of the bigger and possibly more important issues around patient-centred care, shared decision-making, paternalism, we've very much addressed those within the musculoskeletal pathway. It's harder to do those across services, so that's a bigger challenge at the minute. In relation to your question, Jim, so would we have found similar issues 10 or 20 years ago? I think that's a trickier one to answer. So certainly in terms of, so while I've been in post over the last 15 years or so, there's always been a protracted time to access investigations and interventions. I think the difference now is recognising all the push for a more rapid access. I think the paternalism would definitely have been there 10, 15 years ago, but whether we recognised it to be such would probably be different. I think I'll stop there.
Thanks, Claire. So our next question that's come in is for Sarah, and it's from Siobhan. Sarah, Siobhan's saying it's a large sample size for a feasibility study. How did you plan the sample size?
Can you hear me? Can you hear me?
Yes, we can hear you.
You can't hear me. Yeah, I'm interested. You say it's a large sample size for feasibility, but anyway, we planned it based on how many women we would potentially reach, and the particular trust we've worked quite closely with them, and we found that there were roughly 2,500 women would be expected to book to attend a maternity unit at the recruitment site for their 2022 week scan. So basically what we did was we we established that, you know, we used the statistician involved in the study. We're sort of basically using estimates, because we had no idea really how many women were going to actually tell us whether they developed a new episode of low back pain, or how many had a previous episode. So we sort of we estimated from 800 recruited that we would have 20% having existing low back pain, and 643 of low back pain, and at least 20% of those who would be recruited will report low back pain in pregnancy. But we knew we would have a lot of dropout. So with those assumptions, we were sort of estimating with error of 95% 95% confidence interval, half width of 4% or less, and a relative error of 16% or less. And that's really what came out, that we were establishing, maybe targeting 1,000 women to start with the aim of maybe having 200 dropouts. And things changed throughout the study, in that we had hoped to contact women before they came for their scan, but practice had changed and there wasn't any paperwork that went out to women, so we had to actually let them know on the day of their scan, etc. So there were a lot of things that caused problems during the study, and I think based on the sample size that we did have, I think it was unrealistic to expect to reach all those people, because we only had a part-time researcher. But it was really just to see how many we could reach, how many we could retain in the study, and what information we collected, because the information really is not available there on this particular area. I hope that helps to answer your question.
I'm sure it does. That was a thorough, comprehensive answer. I'm slightly worried that the landlord's going to call time on our session. We've got only a few seconds remaining, so perhaps it's worthwhile saying that if you've had a question that you've posted in the chat and it hasn't been answered, use the slides to contact the speaker directly, assuming that they're happy to have that contact, and hopefully they'll be able to ask any pertinent or pressing questions that we haven't had time to go through today, because we've got to stick strictly to time. Is it worth trying to fly through one more question?
I think we're done, Jim. There's also the networking lounge that you could use. So within the networking lounge, you can try and have a chat with the speakers as well. Unfortunately, we start running behind. We'll like Jim said, the bell's ringing for time, I think.
Yeah.
Thank you very much to all our speakers for excellent presentations. And we have a further session on pathways on Friday morning from the National Back Pain Clinical Network, looking at the radicular pain pathway. So please do join us for that session.
Thanks, everybody.
Thank you.